Thank you, Dr. Arvind. I, on behalf of the Liver Transplant Society of India, welcome everyone to this second day of the liver transplantation course. I think we had a very exciting and meaningful day one. More than 600 delegates had logged in, and we had some very good discussions. And hopefully, we'll have a great day today as well. To start off, we have a clinicopathological correlation meet session, the CPC. In this, the clinical discussant will be Professor Mohammed Rela. He needs no introduction. He's the chief surgeon and chairman and managing director of Dr. Rela uh, Institute and Medical Center at Chennai. And along with him to discuss the pathology would be Dr. Mukul Vij, who's the senior pathologist in the same hospital. And I invite Dr. B. Venugopal, the chief surgeon at PGS Global Hospital, Bangalore, to chair this session. And along with him would be Dr. Brigadier Pankaj Puri, who's the head of the Department of Gastroenterology and Hepatology at Fortis Escorts Hospital, Delhi. So I invite Dr. Venugopal and Dr. Puri to chair the session, and I request Professor Rela to start the proceedings.
Can I start?
Yes, sir.
Yes, sir.
Yeah, thank you. I'm sharing my screen. Can somebody say when it's okay? Can you see that?
Yeah, I can see.
Yeah. First of all, I'd like to thank LTSI and Dr. Neeraj Sharaf for inviting me. He asked me to talk about long-term issues with liver graft, and I thought I would address really the immunological late liver graft injury as a subject matter. I'm going to really talk about three conditions, and Mukul, our pathologist, is there. So at the end of each condition, he will show us a patient and the histology. He's going to show us real-time histology. And so the three conditions I've chosen are really chronic rejection, de novo autoimmune hepatitis, and then long-term graft fibrosis, which is now thought to be immunological. Now, we all have been brought up thinking that liver is an immunologically privileged organ, and it certainly is an immunologically privileged organ because it has the capability to really absorb circulating antibodies. The complement levels are very low in chronic liver disease. And also we know that the liver has an enormous regenerative capacity. So even when there is an injury, unlike other organs, solid organs, it's able to repair itself and get back to normal. So graft loss really due to, sorry, I'm just adjusting my, graft loss is much less, long-term graft loss is much less in liver compared to the other conditions. So the evidence that the liver is an immunological privileged organ is shown in combined liver-kidney transplantation. So even the highly sensitized patients don't suffer from rejection, kidney rejection, when it is combined with liver. And it's been very clearly shown that as soon as the liver is implanted, the circulating antibodies are all absorbed and the levels drops dramatically. And this is so effective that now people are even thinking of doing an auxiliary liver transplant prior to putting a kidney transplant in a highly sensitized patients. But having said this, we still have an issue in liver with long-term graft loss. And the long-term graft loss can be due to recurrent disease, cardiovascular diseases, recurrence or de novo malignancies, and finally, really, the rejection on another immunological graft injury, which is what I'm going to talk about now. Now, chronic rejection is a slowly progressive cholestatic disorder. It's an immunological cholestatic disorder. And those of you who have been in transplantation will know and would have seen this as a common problem. I mean, when I started liver transplantation, chronic rejection incidence was almost 20%. And I'm talking about the cyclosporin era. And a significant proportion, I think there was no, at the early days, there was no treatment for chronic rejection other than retransplantation. And if they're not, and it's not uncommon to retransplant these patients many times for chronic rejection once they've had one chronic rejection. And things changed over a period of time. Having said that, the incidence of chronic rejection has come down dramatically. Now, we only see about 3 to 5% of chronic rejection in liver transplant patients. But compared to the other solid organs, I think the incidence of chronic rejection in liver transplant patients is extremely low. And why did this happen and how did this happen? Now, I think everything improved after the introduction of tacrolimus, I have to say. And in Pittsburgh in 1989, when they introduced tacrolimus, I mean, the toxicity of tacrolimus in the early days was extremely high. I don't know any of you have used intravenous tacrolimus. I mean, we used to start off with intravenous tacrolimus and shut down patients' kidneys. And it was really in the early days very fearful. And then the levels that we were trying to maintain for tacrolimus in the early days was 30. And now we are thinking about less than 5 as the level for tacrolimus level. So it was regarded as very toxic. But in the early days, what was apparent was that when you started patients with chronic rejection with tacrolimus, you almost had a 70% survival. So it dramatically changed the outlook of chronic rejection from retransplantation almost in every case to graft rescue in almost 70% of the patients. But nowadays, I think every patient is on tacrolimus, and therefore tacrolimus cannot be used as a rescue unless you want to increase the dose. I think now really the mTOR inhibitors have come to the rescue, and you can rescue. And you need to remember, if patients are developing chronic rejection in spite of tacrolimus, it'll probably be much more difficult to control chronic rejection than in the early days in the cyclosporin era. Now, it's one of the problems with chronic rejection is also the diagnosis. I think most of the chronic rejection comes about without us really expecting it, because a lot of the times these patients will have repeated episodes of acute rejections, and then we treat them and then they don't improve, and suddenly the bilirubin is going up, and then you're thinking about biliary problem. The bile duct is not dilated. Still, you think that maybe it's a very hard liver and land up with biliary interventions. And finally, only you do a liver biopsy when nothing is working and discover chronic rejection. But what is important to understand, even in the early tacrolimus, the first curve shows such an improvement in survival with tacrolimus for chronic rejection, but the second two smaller curves very clearly demonstrate that you need to diagnose chronic rejection early if you want to reverse it. And this study shows that the tacrolimus works best, or in today's world, you must be thinking the treatment for chronic rejection will work much better when you diagnose chronic rejection early, and when the bilirubin was greater than 10, the graft loss was not prevented. Whereas when the bilirubin was less than 10, that is, treating chronic rejection early resulted in a much better improved graft survival. So I think it's important that when we are managing chronic rejection, we do need to think about them earlier on. Now, chronic rejection we see in 3 different clinical settings. One is patient develops rejection, usually a late rejection, maybe a month later, 2 months later after they are discharged. And then it never improves. The enzymes seem to come down and then start going back up, and you've done 2 biopsies and 3 biopsies, you've escalated, treated them with antibodies. The rejection never improves, and then it goes on to chronic rejection. Finally, the liver biopsy done a month later, 2 months later, shows us features of chronic rejection. The second one is really multiple admissions with acute rejection episodes, and finally landing up with chronic rejection. And the third one is really the indolent, which happens over a period of years, maybe 1 or 2 years later, because the patients have not been taking immunosuppression properly, and they have not been monitored properly. So really, about 10% of repeated acute rejections can land up with chronic rejection. Now, there is a list of risk factors. I don't think actually this list is very relevant today, because this list was created during the cyclosporin era, but there is still some association, like viral infections, CMV hepatitis is associated with chronic rejection. gender mismatch. I think male livers in female environment don't do very well. And this again is in the cyclosporin era data. And also racial mismatch, really. Non-Caucasian patients, Black patients receiving Caucasian livers also are prone for chronic rejection. But I wouldn't pay too much attention to this data because the incidence of chronic rejection itself has come down tremendously. And in terms of now, if you see the more recent studies, even if you take here LDLT programs with 1,200 patients, it's only 2%, 23 patients had chronic rejection. And also this LDLT study has shown that the chronic rejection is less. This is 9.4%, much higher than the last study. It's half in the genetically related donors versus 14.7 in the unrelated group. So it's clearly an immunological event, which is a progression of an acute immunological insult, which becomes a chronic insult later on. We're coming to pathology. I think I'll be releasing this for Mukul in a second. There are two things that you have to remember. One is a progressive ductopenia and the other is arteriopathy. Earlier on, people used to think whether both damage is immunological. I think Mukul can answer the ductopenia. See, the duct injury is immunological in acute rejection. We very clearly know that. Whereas in chronic rejection, it's probably the arteriopathy is the beginning event, and then the ischemic insult. As you know, that the ducts are predominantly supplied by the arterioles. The ischemic insult can potentially result in really the duct loss in chronic rejection. I'm going to stop sharing now. Mukul, you have a patient, I think, and where am I? I can't see the screen to stop sharing. Okay, the host has shot from Mukul. You're ready now.
Yes, Prof. I'll share now. So this is the case as we are discussing about chronic rejection. So this is a patient. She was a 27-year-old, this female. She underwent living donor living transplantation in 2013 for subacute liver failure. She was non-compliant with immunosuppression, and a biopsy was done in 2016 with us in Global Hospital, which shows evidence of chronic rejection. And she was advised re-transplantation. She didn't respond to any treatment, and there were persistent cholestasis. Retransplantation was done by us in Global Hospital in May 2016. With this she also developed obesity, and again she became non-compliant to immunosuppression. She developed multiple episodes of increased liver enzymes, and which one of a few biopsies was done, which shows evidence of cellular rejection, and but her bilirubin continued to rise, and an allograft biopsy was done in January 2021. This is the biopsy in January 2021, which I'm going to show you all. So this is the liver course. I hope everybody can see the screen.
Yes.
Yeah, and can we see my cursor also? I'm moving. So
Yes.
yeah. Okay. So you can go through this biopsy. This is the biopsy. You can see these pale areas, and again these more pinkish areas here. If we go into the higher power. This is a portal tract at the end. You can see an arteriole, you can see a vein, you can see multiple ducts, but multiple ducts you can see the cells are not arranged regularly. There is disturbance of polarity in this duct. You can see multiple arrangement of nuclei at one end, and this nuclei, there's a small nuclei here, again larger. So all these changes of atrophy or dystrophic changes are seen in the duct. In this duct also, in this field, you don't see any nuclei. Generally, in a duct, the nuclei are arranged very regular arrangement. So that regular arrangement of the nuclei is lost in this duct, in this portal tract. And
can I stop you for a second? Just show
yes,
that.
sure.
I want people to recognize that the portal tract is not very inflamed. It's expanded, but it's not inflamed. Can you show them the arteriole as well? So
yes, Prof.
This is arteriopathy here.
This is the arteriole.
Predominantly only ductal pathology, but no arteriole. Can you show the right-hand side, the arteriole most on the right?
This, yes, Prof. This is also an arteriole.
Yeah, it's not a duct.
This is the duct here. Yeah. So expansion, there is mild inflammation, and we can see dystrophic or atrophic changes in the bile ducts. There is no loss in this portal tract. So we move on. we move on to the other portal tract. In this area, in the lobule, we can see extensive ballooning of hepatocytes. You can see bilirubin also, this brown discoloration, that is all bile in the physical. The bile is present in the liver. And then you see there's again a small portal tract here at the edge. There is hardly any inflammation. You can see vein, you can see arteriole, but you don't see any duct. There is no duct here. So there is duct loss in this portal tract. The duct and artery, they run parallel to each other. So if you don't see duct around an artery, that suggests you that you are dealing with duct loss in a liver. Again we move on to this is another portal tract here. You can see an arteriole. There are some veins here, some portal capillaries we can see. Again, very mild inflammation, looks like a burnt out portal tract. You don't see any duct here. Now, if you go on in the lower power, you can see that there is a vein here. So there is necrosis and fibrosis also happening in this area between portal tract and central vein. And there is also portal tract here, which again shows only an arteriole. You can see vascular channels, but you don't see any duct, and you don't see much inflammation also. Again, around that in the hepatocytes, they're all ballooned and show lot of pethary degeneration and bilirubin. And bile, we move on. Again, in this area, we can see a lot of bile in the canaliculi also. This is a central vein. Here again, you can see necrosis and you can see bilirubinostasis and ballooning. So with all these features, in this area, this is again a central vein here. You can see fibrosis around central vein. You can see mild inflammation. You can see a lot of ballooning. So fibrosis, necrosis is happening. There is ballooning. There is a lot of bile present in the biopsy. And you are seeing dystrophic changes as well as duct loss in more than 50% of the portal tract. Throughout the liver biopsy, these are the features which is consistent with the diagnosis of chronic ductopenic rejection or late chronic rejection.
Mukul, can you show them that most of the feathery degeneration, balloon degeneration, is seen around the central venule?
Yes, Prof. Yes, Prof. Yes, Prof.
That's it.
Yes,
you
Prof.
can see even in the color.
This one, if you see here, this is around central vein area. You can see most of this ballooning that can be immunological also. Also, there can be ischemic basis. So both things are involved in these kind of features in the liver biopsy. And again, you can see extensively ballooned out cells. These all are very large cells with very rarefied kind of cytoplasm, and they show a lot of bile. All of these cells shows a lot of bile too. Prof,
is there anything else, Mukul, you want to show?
No, Prof, just consistent.
Okay. So to summarize, really, you're saying in chronic rejection, you've got duct loss,
yes,
an arteriopathy that you have not demonstrated in this.
Yes, arteriopathy, because Prof, it involves the medium or large size arteries, which we cannot be biopsied in a true cut biopsy. If you see an allograft, we will see the typical foam cell arteriopathy obliterating the duct lumen. In needle biopsies, we will not see the arteriopathy, which is just characteristically described in the chronic section.
Okay, do you want to close now? I'll share
yes,
my
screen. Yes, Prof. How to
stop sharing?
Yeah, stop sharing.
And I'll go back to my slide. Can you see my?
Yes, Prof.
So really, the three things are really portal tract arterioles dissipating and bile duct showing, and also hepatic venules, zone 3 hepatocytes being looking very sick. This is what Mukul did not show. This is an interlobular bile duct, or I don't know, portohepatous bile duct. You can see the foam cell arteritis, which is really almost occluding the lumen. I think there is the central part is thrombus, isn't it, Mukul?
Yes, Prof. Yes, Prof. Yes.
Central is a thrombus, and the peripherally
it's all foam cells are there.
The cells, the foam cells in the peripheral aspect. This is classical for chronic rejection. So the next entity I want to talk about is de novo autoimmune hepatitis. Now this entity is strangely not fully accepted everyone as an autoimmune phenomenon, I think. The first publication came from King's. It was published in Lancet in 1998. I was very much part of that because this was produced from the pediatric program at that time. The observation was, this was actually an observation from a single patient, a girl who had drug-induced acute liver failure for anti-tuberculous drugs. And then post-op, after 2 years, she developed this, what looked like rejection, but was not a classical rejection. Which showed really the presence of a new development of autoantibodies in this girl. And this actually responded to treatment similar to, really, they escalated the steroids to 2 milligrams per kilogram body weight and gave azathioprine, and everything settled. And subsequently, they saw this phenomenon in 6 other children. So the 7 out of 180 children developed what they described as, what we described as de novo autoimmune hepatitis. And many people still refuse to accept this as an idea and want to see this as a different manifestation of rejection. And they would call it a plasma cell rich rejection. Late rejection is probably what it is. Whatever you want to call it, I think it is a very distinct entity which is described and which many people have really replicated. It's not just the King's program which described it. Here we have Ron Busitel UCLA program identifying it in 41 patients out of 619, somewhat a similar number. And what these people are now beginning to say is this is more or less like rejection, because they have found out that similar to chronic rejection, the more number of rejections that you see in these children, they are more likely to have this phenomena, or at least patients presenting with this phenomena have had more number of rejections, more number of biopsies for rejections. And also these have been patients who have not come off steroids, because in the pediatric transplant, they have been trying to take them off steroids. And if you look at this, the case control, only 8% of these patients have really come off steroids, indicating that this is probably a phenomenon of rejection, and which is just a continuation as we saw. I just want to put these, because this is really only 3 slides to tell you the risk factors, again, which is in supported that this could be a kind of rejection. The risk factor shows patients with the withdrawal of corticosteroids or early withdrawal of corticosteroids are more prone for it. Inadequate immunosuppression secondary to non-adherence is all what we saw with chronic rejection. Patients on single immunosuppressive drug are all prone for really de novo autoimmune hepatitis. The diagnosis is basically by exclusion. You have to exclude all of these acute chronic rejection, hepatitis C, B, everything. But in addition, what you see is elevated IgG and positive autoantibody titers, which are not there preoperatively. I think it's very important. And also, there shouldn't be transplants with a history of autoimmune hepatitis. And histologically, what you see is plasma cell rich, and the treatment is really treatment of continued treatment with autoimmune hepatitis, not withdrawing steroids, escalating steroids and azathioprine, and azathioprine doesn't work. You treat them with mycophenolate. I'm going to stop sharing now, and Mukul will show us a patient with de novo autoimmune hepatitis.
Coming to this patient, she is again a female, a 58-year-old female who is known case of type 2 diabetes mellitus as well as hypothyroidism. She developed non-alcoholic steatohepatitis related ESLD. We did a transplantation.
Mukul, we are describing an autoimmune history for this patient, type 2 diabetes as well as hypothyroidism.
Prof, in the explant, there was no evidence. It was NASH-related ESLD.
Yeah, I know. But in the risk factors, these are risk factors for autoimmune hepatitis.
Yes, Prof. Okay. Yes. So she underwent living donor living transplantation in May 2017. The standard reconstruction was discharged within 20 days. She developed with some elevated enzymes in October 2017. A biliary stricture was identified at that time, and stent was placed. And then the further treatment of cholangitis was also done. And she was okay till September 2020. She again came to us with increased LFTs, and an allograft biopsy was done at that time. This is the allograft biopsy which I'm showing you. You can see a linear core of liver tissue, quite a good biopsy we have. And what we see again, we can see these expanded area, these blue areas here, these expanded portal and with fibrotic areas these blue areas and these pink areas. So if we go into the higher part, what we see that there is inflammation in this. There's quite a bit of inflammation. Portal area, you can see a vein, you can see an arteriole, you can see an arteriole, you can see a duct, you can see a vein also. And if we go into the inflammation, we see all are plasma cells. You can see these all are characteristic plasma cells with eccentric nucleus and abundant these amphiphilic cytoplasm. It is filled. All these are throughout the plasma cells. In this inflammation, there is also necrosis is also happening here. So there is exportal fibrosis expansion as well as necrosis in this portal area. You can also see again a bridging fibrosis happening here between this portal tract and this portal tract. Then we move on to another portal tract. Again, quite a bit of inflammation. Yes,
can you show them a lymphocyte and a plasma cell? Because I want people to see a large
Prof, this is a plasma cell. We can see this is a bigger cell. This is a lymphocyte here. This is a plasma cell, and we can see cytoplasm. In lymphocyte, we will not see any amount of cytoplasm. The cytoplasm is very scanty as compared, because of immunoglobulins. The cytoplasm of the plasma cells is moderate to abundant, and we can see this typical amphiphilic cytoplasm. This is a eosinophil here. So this is a lymphocyte and this is a plasma cell. That's how we differentiate morphologically. We can also do a marker. We can do CD138 for that also. Throughout, again, lymphocytes, lot of plasma cells here. They are extensive, more than 30% plasma cells, and there is fibrosis. Again, you can see that there is fibrosis happening between portal fibrosis happening. So this is a chronic hepatitis with lymphoplasmatic inflammation. There is also evidence of interface activity. Some interface activity is happening here. You can see the disturbance of the portal plate here. This is spillover of the inflammation from the portal area to the periportal parenchyma. So portal inflammation, which is rich in lymphoplasmacytic, there is interface activity. There is fibrosis. There is fibrosis going on, and also one of the very important features of plasma cells or de novo autoimmune hepatitis is confluent necrosis around central veins. This is, you can see this lot of inflammation, lymphocytes and plasma cells. This is a central vein here, and you can see lot of confluent necrosis around here. So with these characteristic features, we concluded that we are dealing with the case of de novo autoimmune hepatitis / plasma cell rich rejection. Just to show you that there is lot of fibrosis also happening in this case. You can see the extensive bridging fibrosis. So we are dealing with the case of chronic hepatitis with lymphoplasmatic inflammation. There is no duct loss. There is no evidence of acute and chronic rejection here. There is confluent necrosis around central vein, which is histologically consistent with the diagnosis of de novo autoimmune hepatitis.
Thank you, Mukul. This is not an acute rejection because it's plasma cells rather than lymphocytes. There is interface hepatitis activity like you see in autoimmune hepatitis, and there is no duct damage with fibrosis, indicating it's a long-term injury. Okay. I'm just going to share my slides now. So going on to the next condition is long-term graft fibrosis. We didn't think this was immunological. This is a phenomenon which has been observed mainly in pediatric liver transplantation because when these children had really protocol biopsies after 5 years, 10 years, 15 years, and some people observed that there was fibrosis in these livers. And there was also some concern whether patients who had lower immunosuppression had more fibrosis. I'm again starting off with the King's publication from 2018, where they looked at the histopathology of retransplantation, allografts removed for retransplantation over a 27-year period, and they divided into 3 periods. There was one unusual finding that they found that in the third era, in the 2002 to 2014, there was an unusual cause of graft loss. So these are long-term patients, so probably didn't see in the early era. 14% of patients lost their liver due to some chronic fibrosing hepatitis. So this is, just keep it as a finding, if you keep it as a finding. Now this Chicago study, again a large pediatric program, found similarly in the long-term survival of pediatric liver transplantation, there were many patients, the protocol biopsy showed almost 97% of patients had graft fibrosis. So 0 stage of fibrosis was only seen in 3% of patients. And stage 1 was seen in 48, and stage 2, stage 3 was seen almost another 48, 49% of patients. So this is a very common finding when you start doing long-term biopsies on these patients. And they also found that if you did these biopsies greater than 6 years, more number of patients had fibrosis, long-term fibrosis. So whatever the reason, whether it's an ischemic injury to the liver, the long-term and immunological injury to the liver, and they didn't necessarily have inflammation in these livers. And really, Birmingham were one of the people who identified this. It's not this publication. They've now summarized to see that grafts are not normal in the long-term histological histology of these children. Grafts were not normal, and fibrosis was very prevalent. And there was a little, I don't know if people, and at that time, there was a little bit of a competition between King's and Birmingham. The King's patients always had steroids maintained, even at 1 milligrams over the long period of time, these children, whereas Birmingham withdrew the steroids. And Deirdre Kelly finally wanted to say that whether continuation of steroids had a role in these patients. Is there a role for corticosteroids in preventing chronic hepatitis? And she also admitted to the fact that there may be an immunological event involved. So it's a Japanese who identified that graft fibrosis was associated with DSA to the class 2 antigens, really. This was a link up between DSA and graft fibrosis in the late pediatric allografts. The interest on this subject was really taken up by the Dallas program, Baylor program, where Jacqueline O'Leary, she's an adult hepatologist, I think, wanted to look at really DSA, chronic rejection, ABO compatible transplants, really, antibody-mediated rejection as a problem. I think now they were able to demonstrate DSA much better than the earlier series, probably because of better laboratory techniques which were available. There has also been an interest in antibody-mediated rejection because of an interest in immunosuppression weaning. There have been many studies on withdrawal of immunosuppression and tolerance. I think this fact actually really puts a little worry into withdrawing immunosuppressions for patients. You may require a very small amount, but these patients, if they are developing graft fibrosis over a period of time or maybe developing late rejection, will look at that. Now, I think DSA in transplantation is very well studied actually in the kidney transplant. It's nothing new, and in patients who are developing antibody-mediated rejections, the DSC levels have remained high in the post-transplant period. And it's well known that association of preformed DSA is associated with much less graft survival. So in solid organ transplant, it's a well-recognized fact. But the Dallas wanted to prove that what we believed as livers are capable of absorbing all preformed antibodies may not be so true. And she retrospectively looked at 1,270 patients and went through their DSA from the stored blood and found that even in liver, what we felt was an immunologically really protected organ, the incidence of rejection whenever there is DSA to class 2 antigens, it was higher. And both for class 1 and class 2, really the patient survival was probably around 10% inferior. So she felt that antibody-mediated rejection is probably there, less diagnosed, and probably more indolent and seen as late graft fibrosis. She also actually suggested that they are responsible for even acute rejections, and there have been many attempts at demonstrating really proving the fact that there may be antibody-mediated rejection when acute rejections don't respond to treatment. Now, our interest is really not the acute antibody-mediated rejection. My interest is really about long-term biopsies in these patients and why do they have fibrosis. So it really boils down to looking at not the preformed antibodies, but the de novo antibodies that develop in these patients. And again, the Baylor series have said that 8.1% of patients can develop de novo DSA after liver transplantation. Really, they are the patients who are at higher risk of forming these antibodies are patients who are on low immunosuppression load, patients who are on a low immunosuppression. And also infections and inflammatory events can sensitize and actually precipitate an antibody-mediated rejection. So this is her hypothesis. I don't think it's been well fully accepted. Many people claim that this is an overdiagnosis, but it does create a problem for those people who want to withdraw immunosuppression in the long term for children. Because if you completely withdraw immunosuppression, it's a known fact that if they develop a viral infection or any illness, it can trigger rejection, and then they may even lose a graft. So it is a worry that withdrawal of immunosuppression is going to be a problem. And many others have also demonstrated the presence of DSA after transplant in patients. So really the pathologists working group joined together to define what should be considered as chronic AMR. I'm not going to talk about the acute AMR as I said earlier on. And if you look at Mukul may show long-term graft fibrosis histology, I think to diagnose a chronic active AMR, you need to have a combination of a histological diagnosis where you see at least moderate periportal and perivenular fibrosis, possibly some mild inflammation, mononuclear portal inflammation, but many patients don't have inflammation. You have to have a recent circulating DSA in serum samples, and also at least you have to show focal C4D staining. Mukul might say focal may not be important. I leave Mukul to talk about the histology of long-term graft fibrosis and maybe his opinion about long-term graft fibrosis and how we deal with it. I think maybe that's my last slide. I just read through it. So DSA-related graft injury is emerging as a factor for long-term graft loss and should be considered in idiopathic graft dysfunction. Diagnosis, prevention, and treatment can help to avoid the 10% graft loss in the late phase. But the caution is overdiagnosis is also a concern because treatments for these chronic AMR is not that straightforward. I think I finished there, and then we can have a discussion. Stop sharing now. Oh, okay. And Mukul can show histology, and I'm finished with that.
So I'll show you, I have two cases here and both are pediatric only. This first patient, he's a seven-year-old boy transplanted by Prof only at Global Hospital in 2015 for biliary atresia. And he is well, 2021, patient is well. There is no evidence of rejection, immunocompliant, doing all daily activities. A protocol biopsy is done in this patient. The LFT, everything is normal. There is no evidence of antibody, and what we see, this is the core. This is 6 years after transplant, and what we can see here, there is in this portal area, the duct is maintained, very regular duct. This is again another little larger duct here, again some duct here, and there is expansion of the portal area. There is arteriole is okay, vein is also okay, and mild lymphocytic inflammation in this biopsy. This is 6 year post liver transplant. Again, if you go there is some expansion here. And again, if you see another portal area, again, there is some expansion here also. This portal area, a very unremarkable duct here. There is some expansion of this portal area. Few lymphocytes you can see here and there, not hardly any inflammation in this. There is some glycogenited nuclei in this patient. And Another portal tract, again, some very minimal expansion, few lymphocytes here. Not much fibrosis, very mild or minimal fibrosis, you can say. If I show you the trichome stain, because in chronic allografts, the criteria, staging or grading what you do for typical chronic hepatitis does not work, because there is evidence of portal, sinusoidal, as well as perivenular fibrosis. So a special grading has been given, which is liver allograft fibrosis score. So if you apply that, which takes into account of portal, centrilobular, as well as sinusoidal fibrosis. So you see in this portal area, you can see this septa, this very thin septa coming out. So there is some evidence of fibrosis extension in the portal area here. Hardly any inflammation. It's not even expanded here, but you can see some extension of the sinus in the sinusites. There is some fibrosis here around this portal tract. Here also, if you can see, there is extension here, which is normally not present. In around this central vein also, you can see there is some extension of the fibrosis around this central vein also. You can see this very thin sinusoidal septa. So there is some mild fibrosis in this, mild portal or periportal fibrosis, and mild perivenular fibrosis in this, which will, if you do the allograft score, it will come into 1 + 0 + 1, which is just 2 only out of 9. So minimal fibrosis there. C4D was done in this patient for this, and it shows very minimal staining, very difficult to just generally you don't see much of C4D, but you can see some this around this vein. You can see some at the base of the vein. There is some this brown discoloration is here. Some stroma, some stroma is showing some dots here. Again, if you see in this portal area, you can see some stromal deposition of the C4D in this case. So very minimal C4D deposition. I don't know what's the significance of this. DSA is not done in the patient, and it's showing very minimal or mild fibrosis in this patient. Then there is one more patient.
So this patient, Mukul, I would do nothing. I think to call this chronic antibody-mediated rejection is a little overcalling. These children are completely normal. They may have a progression of fibrosis, but I don't think there is anything to be done. We probably overtreat if we start treating these as antibody-mediated rejection.
Yes,
so
yes.
I've done nothing for these patients. And the biopsy, I wouldn't have done a protocol biopsy. The biopsy was done by the pediatrician looking after the patient in Bombay. So, I mean, it's an interesting case. So we thought that not all grafts or majority of the grafts in the long term won't have a normal biopsy. Mukul, go on.
This is another case. This is another, again, pediatric patient, which was within a year a biopsy was done, because there is mild allograft dysfunction, also transplanted for PFIC. And in this biopsy, if you see there is some derangement of liver enzymes. Definitely, you can see there is expansion in this portal area. You can see this very well-formed arteriole. There's a vein. Sorry, it's on the edge, so this is cut here. And you can see a duct here. Definitely, there is some expansion. There is mild inflammation in the portal area. Around central vein, you can see some inflammation, which fits into the criteria of this is antibody-mediated rejection is happening. Again, in this portal area, definitely this portal area there is expanded. There is fibrosis happening in here. Duct is unremarkable. Arteriole is unremarkable. Portal vein is largely, there is no venopathy happening, which is also one of the histological criteria for CMR, but there is expansion and there is minimal inflammation in the portal tracts. If you go throughout around central vein also, there is some fibrosis. Again, there is some fibrosis in this biopsy, and in this you can see little more inflammation. You can see rare eosinophil also. If I show you the trichome is this, definitely then you can see that there is fibrosis in this very mild inflammation in the portal and perivenular area, but definitely there is some amount of portal fibrosis in this patient. In this C4D was done and it shows some deposition. I'll show you again just that C4D in this patient. And there is some deposition of C4D. Again, DSA is not done. I think a lot of cost issues are there to do C4D in our country. But if you see, there is some stromal deposition here. Definitely more than that, what you see in that 6 year of post-transplant. In this, there is some stromal deposition. You can see portal capillary as well as some stromal deposition. Here again, a capillary is here. This is showing some C4D here. Definitely more than focal. more than focal. And again, you can see some of the portal capillaries here also. Some of the venues is showing some C4D deposition, which looks like at least more than focal, probably 20% of something. So with C4D, there is some fibrosis, some activity, maybe some immunological or antibody-mediated humoral rejection is acting in this patient. Again, DSA is not done. Thank you.
Thank you, Mukul. I stop here. I mean, I think this patient, if has very abnormal LFTs, will warrant really treatment. You would this would have been treated as a conventional rejection first, and if it's not responsive, would have had a biopsy. So you might consider treating that patient as antibody-mediated rejection. Is there any points to discuss now, or we're running? We still have 5 minutes, I think. Or we done? Maybe we have finished.
So we can have a few questions. Yeah.
Yeah, question to Dr. Vij. How do you differentiate chronic rejection from recurrent autoimmune diseases like TBC?
PSC, basically PSC and recurrent cholestatic diseases. Yeah. So that's an important question. I think the most important thing is duct loss, which you can see in both, but there is no ductal reaction, which I actually didn't tell you at that time. You don't see, because in chronic rejection there is apoptosis as well as the ductules, the stem cells which are around in the canal ring, they can't proliferate. There is loss of proliferatory activity as well as support. So you don't see any ductal reaction. That is one of the things. And then around the central vein, so much of ballooning, there is necrosis, fibrosis, all those things happening. With that, you can always suspect that you are dealing with either chronic or in any cholangiopathy, you will see a lot of ductal reaction, you will see portal edema, portal tract will be much more expanded. In this, you see a bunt. In chronic rejection, you see bunt out portal tracts. They hardly show any inflammation. Sometimes even late stages, even arterial loss would also be there. So you don't see any structure, and very difficult to differentiate that you are dealing either with a portal tract or a central vein fibrosis. So in a cholangiopathy, you will see a lot of expansion, edema, you will see neutrophils in the portal tract, and also sometimes bile plugs also in the reacting ducts. That's how you can differentiate.
It's quite a different pathology actually, because in one you got bile duct proliferation, in the other you've got bile duct loss. In one, it's really acellular expanded portal tracts. In cholangiopathy, it also has neutrophils.
Neutrophils.
So it's not very difficult to differentiate.
Those were excellent slides, Dr. Mukul and Dr. Rela. Thank you. You were brilliant as usual. You know, what struck me with my short stay with him in King's was, with due apologies to the surgeons, that he thought like a physician. And he could read all those slides, which was amazing, which most people couldn't. And I think this was a wonderful session. With that, we should hand over the mic back to the organizers for the next session. Thank you.
Dr. Bernova, there are a few questions in the chat box. Can you take them?
Yeah.
Oh, I didn't see any.
Yeah, there are.
It's in the question answer.
Is there any relationship between de novo autoimmune hepatitis and humoral rejection? Is there a role for doing CD4 immunostaining in biopsy?
Yes. Should I answer that, Prof?
Yeah, please.
Yeah. Actually, the de novo is also considered a kind of antibody rejection, because what actually was shown in earlier papers that in Caucasians, where there is an enzyme in hepatocytes, there is drug metabolism, which is GST, glutathione S transferase. In 20% of Caucasian, it was not present. So when you transplanted those livers, a donor liver which got that enzyme on the hepatocytes, that protein is present, and you transplanted in a recipient which lacks of it, because 20% does not have that. When you transplanted those livers, they developed de novo autoimmune hepatitis. Those 6 patients, what they saw, they all developed autoimmune de novo autoimmune hepatitis. So you can see, because antibody was formed again, that GST was considered foreign in those recipients, and that led to development of de novo autoimmune hepatitis. And that's why you can see C4D positivity also. Actually, I have done also, then I didn't show you, but there was some C4D deposition in those cases also. So it is also considered a part of a kind of AMR also, de novo autoimmune.
I mean, it's common sense to think it's just loaded with plasma cells, which are loaded with antibodies. So there must be an association between de novo autoimmune hepatitis and antibody-mediated rejection. Really.
Question to Professor Rela. In the study regarding graft fibrosis in protocol biopsies among the long-term survivors post-liver transplant, was there any particular etiological association?
I don't know if it's very similar really. The etiological association with graft fibrosis again mainly was patients on very low immunosuppression was one. Single immunosuppressive drugs, patients not on steroids was again an association, and that's why we have to think of this again as a possibly related to some form of very indolent rejection. So it again they were associated with low immunosuppression, which is why I said that this puts a question mark over immunosuppression withdrawal trials.
The last question to Prof. Rela, how to treat chronic antibody-mediated rejection?
I think if you look at, maybe let me just put a slide there because I removed that slide because I didn't want to talk about that. Let me share. Hold on. It's the same with rituximab and immunoglobulin, and those are the treatment options. There is your treatment options there. For the de novo is again steroid pulses, plasmapheresis, rituximab, OKT3. I mean, the treatment options are not that straightforward. That's why I'm saying to treat somebody who's asymptomatic, who's done a protocol biopsy and you find fibrosis, and then to start treating them with these drugs is not really practical. I don't think we have treated any of these patients. They've been observed to have fibrosis over long periods of time without much effect on the graft function. But then I have to say that there were 14% of patients who lost their graft due to graft fibrosis as well in the King's.
So at what stage would you consider treatments?
They are symptomatic, and if they certainly present with transaminitis, then you would want to be treating them. But just protocol biopsies on patients which just shows bland fibrosis with no inflammation, I wouldn't be considering treating them until people. I think this is still, in a sense, very hypothetical, really. You would only treat them if you think that you're going to lose the graft or something. I don't think you will just call somebody home for a 5-year, 10-year biopsy and then tell them that you need to be treated for rejection. I would find it very difficult to do.
With that, we close this session and hand over to the next session.
Yeah, thank you, Professor Rela and Mukul. That was a wonderful presentation. And thank you, Dr. Puri and Dr. Venugopal for chairing this session.